Good afternoon, everyone. I'm Lori Taylor, Director of Marketing with myMatrixx, and I'd like to welcome you to our webinar series this afternoon. Today's session is on DME advances and proper utilization in workers' compensation. Before we get started with the session, I'd like to cover just a few housekeeping items. Today's webinar will run 1 hour. It's being recorded, and it will be available within 1 week on our website, which is mymatrixx.com. CE credits are available for work comp adjusters in California, Florida, Georgia, and Texas. We're also offering CCM credit and RN credit for all states except Indiana. You will receive an email within 24 hours regarding credit. Please register for credit using the link that's provided in that email within 10 days. We will be taking questions. We're going to save time at the very end. So please submit any of your questions in the chat pane for the presenters, and we'll address as many as time allows. Now, in today's session, the presenters are going to cover an industry overview. They'll go over what is DME, what DME currently is commonly utilized in workers' compensation, delivery methods and advancements in the industry, billing codes, tips on product selection, and give you an idea of average utilization and costs. And again, we'll be doing a Q&A at the very end. So I'd like to go ahead and get things started. I want to introduce our panelists. We have Jean Feldman, who is a new addition to the myMatrixx team. She just recently joined us. She has over 25 years of experience in workers' compensation and care management. She's Vice President of Ancillary Operations and is responsible for managing the operational activities of myMatrixx's Ancillary department. And as a licensed registered nurse, she brings a unique perspective to the team by providing cost containment solutions while keeping patient care a top priority. And then secondly, we have Chuck Sweat. Chuck is the Vice President of Provider Relations with myMatrixx. He has been instrumental in developing and maintaining myMatrixx's nationwide ancillary provider network. He has 25 years of experience in workers' compensation with a focus on ancillary services, DME, home health, and medical supplies. So with that, I'd like to go ahead and turn things over to Jean to get things started today.
Great. Thank you, Lori. What we're going to do first is just to give an industry overview and to put DME in perspective. So the first slide is information from the Centers for Medicare and Medicaid Services. DME spending in overall health expenditures was over $37.7 billion in 2010. So looking at the total picture, there is a lot of money that's going into durable medical equipment. Spending for medical supplies was over $44 billion in 2010. So again, DME is projected to increase consistently at an average rate of 6%. So based on these projections, DME spending could exceed $50 billion by 2015. And again, this is in the overall health care, and we will move more into the workers' comp going forward and how that impacts us on our side. NCCI did a recent study in 2013 in January, and they were actually looking at a group of claims that are 20 years or older and what were the cost drivers in these claims. As no surprise to anyone on this call, medications made up 38% of the cost. However, DME and ancillary services are also a major contributor to these older claims. Supplies were at 8%, home services at 9%, general services at 8%, and then they also did find surgery work costs as well as facility care for these older claims. And then some physical medicine and office visits were at a smaller percentage. So common workplace industries, and this is, again, this is from the Bureau of Labor Statistics. Sprains, strains, and tears are the major contributing injuries that really impact return to work and impact lost time away from work. The other ones, as you can see as you go down the table, cuts and lacerations, bruises, contusions, soft injuries are impacting our costs in workers' comp every day. And as you are well aware, they get more complex and more difficult to manage. They require more interventions, more treatment, more other types of services start to get involved as these claims age. And back injury also impacts and are a part of those sprains and strains. And according to the NCCI research brief on medical services, the claims requiring treatment at 20 years and plus include disease of the musculoskeletal system. So the major injury causes were musculoskeletal injuries. Now the interesting thing about what NCCI found is that there really is a difference between the genders, between women and men in most categories, which is interesting. They didn't really delve into why that was happening in the report, but there is a difference. And again, these are claims that were 20 plus years. So when you look back at 20 years, there is a difference probably of women in the workplace and what we were doing at that time, but they still couldn't account for such a major difference because of the musculoskeletal system. There's a 10% difference between men and women, which is interesting. So I'm now going to turn this over to Chuck, and we're going to start going into durable medical equipment. And of course, as we know, this does drive up the cost of our workers' comp claims, and there are changes that go on consistently as new things are developed in the equipment world and what our patients then are going to have as far as their treatment plan. So Chuck, we'll turn this over to you.
Great. Well, thank you, Jane. And thank you all for joining us today. We appreciate the opportunity to walk you through this the CEU program. So we'll dive right into it. And the topic is, what is DME? DME really stands for Durable Medical Equipment. When you look at ancillary services are really any product or service that's performed outside the hospital setting typically. And in that includes DME. And you have other products and services which would include medical services, medical supplies, home health care, orthotics, prosthetics, diagnostic imaging, and a whole slew of products that are typically performed in the home. DME can also be referred to, you may have heard it called HME, home medical equipment, durable medical supplies, home care products, and DME POS, which is really an acronym from Medicare, which stands for durable medical equipment, prosthetics, orthotics, and supplies. So it's a full grouping of products and services offered. When you define true DME, it's really stated for repeated use. You have a product that can be purchased and used repeated times. It's primarily in customary use for medical purpose. It doesn't have a typical purpose for someone who does not have an injury. It's appropriate for home use. They are typically prescribed by a physician or a physician's assistant, a nurse practitioner, a clinical nurse, or a specialist. Physicians may also prepare a certificate of medical necessity or a letter of medical necessity depending on the product or service being requested. Many times they feel that as adjusters and case managers that if we're able to provide that information where you have the prescription and the supporting documentation, you're able to make a better call if it's medically necessary for your patient. So some benefits of DME in the home. If a patient's in the home, there's a lower cost, there's more comfort for the patient, recovery times tend to improve, they have the family support. So if you look at the lower cost aspect, products provided in the home are typically between 200 to 700% less expensive than what you would pay for in a hospital environment or hospital setting or a long-term care facility. Comfort, the patients are in a familiar environment, they're comfortable, they have their loved ones with them to support them. Recovery time tends to improve because they're now more mobile and they're able to recover faster. The families have the patients at home, so they're not separated from their loved ones. They can be involved in hopefully more of the day-to-day activities that prompts them to get back to work quicker. The commercial that's out today, right? The body that stays in motion, or the body in motion tends to stay in motion. So the patients who can have mobility, they're able to recover quicker and return to work. So commonly used DME type products in the workers' compensation market. You probably recognize most of these: ambulatory aids, canes, crutches, walkers, bathroom safety, 3-in-1 commodes, transfer benches, hospital beds, CPMs, bariatric equipment. Bone stimulators are very common today. Electrotherapy, medical supplies, oxygen and respiratory, hearing aids. So now what we'll do is we'll just take a look at some very common products and give a little bit of information about each of these products. So under the ambulatory, we would have canes, walkers, crutches, and most of these products are made out of aluminum today. Most of them are adjustable for height, for length of arms. They're more compatible for transport today. They fold and they store easily. The cane, for instance, is good for light stability for injuries such as sprains and strains. A walker has a 4-point touch, so it has greater stability. You can adjust the height of the walker. You can also add wheels, brakes, and other attachments to a walker. Crutches, they have height adjustment, not just in the pin adjustment, but also in the hand. So depending on the patient's length of their arm, they're able to make those adjustments as well. Bathroom safety equipment. If you look at our homes today, the most dangerous room in the house is really the bathroom. It's typically wet, it's slippery. The patient's trying to transfer in and out of the tub into the shower. They're trying to have a seat on the toilet, and they need support getting up and down. Typically, bathroom safety equipment works well for patients who have mobility issues, low back injuries, or upper extremity injuries. So the bathroom safety equipment, and we'll go through further detail on each one of these products shortly, but allows that patient to sit comfortably and safely within a very dangerous area of the tub or the bathroom and perform the necessary duties. So hospital beds. Hospital beds today are both for long-term use and short-term use. They are commonly used for low back injuries and lower extremity injuries. There's 3 main types of beds today: a manual bed, semi-electric, and full electric. The semi-electric is the most common, and once again, we'll go in a little more depth shortly on these products. The other products that are very common today are ADLs, aid to daily living. Basically allows that patient to have some normal function back in their life. Through an injury, if the patient's unable to bend or stoop, a reacher works well from the reach and grabs. They don't have to worry about falling out of the wheelchair. They can use the reacher to grab things off the floor. They can also use build-up supports and hand braces to help feed themselves. And it's an easy way for them to have some return of independence. So wheelchairs, when you're speaking of wheelchairs, you can have a basic wheelchair, an 18 by 16 inch wheelchair, good for 250 pounds, swing away leg rest, or you can go all the way up to a very high-end wheelchair, a sip and puff, a chair that has a tilt and space program in it. So the patient then can remove spasms by tilting that chair. They're able to move the chair by simply sipping and puffing to move forward and backwards. A chair very similar to what Christopher Reeve may have experienced. Cost obviously goes from $200 to $50,000, just depending on the wheelchair and the unique needs of the patient. A very common product today is the CPM and cold therapy, and I'll also throw in the same mix post-op bracing. So if someone's having some type of joint surgery, whether it's from an injury, often they will receive a CPM for that specific body part, cold therapy, and some type of post-op brace. Many times the cold therapy units are applied actually during surgery by the physician, so they're delivered to the hospital, applied to the patient. The CPM is normally delivered to the home, and the goal of the CPM is really to get full extension and full flexion of the joint. So if the patient has, they're maybe seeing a physical therapist, and they also get the CPM. So once again, those two pieces combined will hopefully speed the recovery time of the patient. And the cold therapy is very common. It helps reduce the swelling and the pain. The post-op brace will then provide support that's needed for that recently surgery. Bariatric equipment. Bariatric equipment, once again, comes in a variety of forms, and it comes across all the DME products that we just spoke about. Those products can be expensive for bariatric products. They're not readily available. Many times for products that would normally be for rent, they only be for purchase. Coding becomes an issue on these products as well, which we'll dive into here shortly. But these products are available, but it may take some time to get them. Medical supplies, once again, actually we included it here because, once again, as we go back and look at the definitions and how people define DME, medical supplies really gets grouped together under DME. But it can be typically medical supplies or for a single patient, single use, one-time use, disposable item. There are a few items that can be reused, but really they're typically single use, single patient. Some examples would be the gauze, catheters, underpads, gloves. Delivery methods. So for all these products and services that we just mentioned, there are really 5 common methods of delivery today. The local delivery, the drop shipment, physician and clinic dispensing kind of go hand in hand, manufacturer distribution as well. So let's talk about each one of these. So local delivery, typically for products or services that the patient's being discharged from a hospital, these products are delivered to the patient's home by a trained technician. There's instruction giving, there's education, and the patient then is able to use these products when the patient has completed their therapy or their healing process. These products, many times, can be returned if they're a rental, and the delivery driver will come back out and pick those products up. Common products for delivery would be bathroom safety equipment, hospital beds, respiratory type products, anything that needs setup and education for the patient. Drop shipments. Products are shipped by a provider to a patient's home via a delivery system. FedEx, USPS, UPS, what have you, they're able to ship those products directly. Typically, the type of products that drop shipped are medical supplies or products that do not require additional fitting or education. The third caveat would be a product that may be taken to, that a patient may receive and receive instruction from their physical therapist or from the physician's office. Physician dispensing. So in today's marketplace, doctors are looking for every revenue source they have available to them. So physicians are more and more doing dispensing of products themselves. And the way they do this is that they'll partner with companies who do programs called stock and bills. Basically, an organization will come in, they will rent a space within a physician's office. The physician's not being paid for referrals, they're being paid for the space in that office. The company then typically stocks the product. Chuck walks in, he needs a walker, the doctor prescribes it, writes the prescription, and he hands Chuck the walker, and then the stock and bill company who worked with the physician to rent the space will then do the billing and collection of that product or service. And that seems to be happening more and more in today's market. Typical products that you'd see this happen on would be electrotherapy and simple mobility aids. Clinic dispensing works in almost an identical fashion. Space is rented, products are stocked, products are then handed out. The billing company then does the billing and collections of those services. The challenge in both of these situations, well, I'll tell you what, let me cover the third point, and then we'll talk about challenges. Manufacturer distribution. There are manufacturers who will perform both the physician dispensing as well as the clinical dispensing, but they will also then take products and ship directly to patients and provide a local rep to go out and do the product education. The challenge with all 3 of these models that many times products are dispensed prior to having authorization, prior to getting the proper approval, getting the proper education, and there's a high cost many times associated with these products where you may be able to receive a similar product from your preferred ancillary benefits manager company and be able to save money and maintain a proper authorization process. So when we look at the ancillary delivery advancements, there are companies out there who provide management of ancillary services. They coordinate care for injured workers. They're fast, they're easy, they make it cost effective, They're a tool that relieves work for the adjusters and for the case managers in providing statuses and updates and a variety of products from a single source solution. In the marketplace, you also have specialty provider networks such as radiology, transportation, and physical therapy. These are companies and networks that specialize in those unique aspects of our marketplace. They're focused, they're able to deliver those services through vast networks that they've built. Another key aspect in the industry is really having specialization of industry experts, meaning that we have a patient being discharged today from the hospital. He's a catastrophic injury. He needs certain products and services to get him home. Through his recovery process, he will need additional equipment and services, such as he may need that power wheelchair we spoke about. He may need a home modification. He may need a van conversion. There are companies out there who have certified representatives who are RTSs, rehab technology specialists, and ATSs, assistive technology specialists, will go out, evaluate the patient, evaluate their home environment, and evaluate the specific needs this patient needs, not necessarily what that patient wants or what the family wants, but what is truly medically necessary for that patient. For instance, how's that patient going to get his wheelchair in and out of his home? How's he going to get into the vehicle to transport it? Is there a ramp needed? If so, what type of ramp is needed? What's the length of ramp based on the level of rise? What's the specific needs that patient has for the wheelchair? Do they need an environmental control unit? Do they need special modifications to their vehicle? Does the vehicle even work for the type of chair they need? So they're really true experts in the market who look at the medical necessity of the patient and the product. So if you're looking at product advancements today, there's tracking and monitoring capabilities, portability, selection, and customization. So tracking today, in the marketplace, patients receive those electrotherapy units. They receive the bone stimulators, and the patient gets them. And do we know if they're compliant? Not always. But most of these products nowadays have a chip built into them, at least the higher-end products. When you're speaking of electrotherapy, the IMPI, the RS Medical, those companies typically have the chips that will allow you to see if the patient is truly using the unit or if they're just turning it on and setting it off to the side. Same thing with bone stimulators. With bone stimulators, the patient goes in to see the physician. There's a chip that can be removed and sent off, and you can get the utilization reports back. Is the patient being compliant? Are they doing the 4 hours a day they need for their bone stimulator? Are they doing the 10 hours a day? Or are they just turning it on and setting it in the corner? Portability. Products today are much smaller. They're simpler to use. So that encourages the patient's compliance and yields faster recovery. Products that were 8 by 8 in the past for a TENS unit, you can now have a TENS unit that's 2 inches by 3 inches by a ½ inch thick. That's digital and easy for the patient to use. Selection, once again, there's diverse availability. You have TENS units that are $65 in nature and TENS units that are $500 in nature. And there's and much of the functionality that exists on the $65 unit will exist on the high-end unit. There's questions regarding how comfortable the therapy the patient is receiving, but the day-in, day-out functionality remains very similar. Customization, utilization of technology, and once again, having those specialists in the marketplace who will go out and do the assessment for the patient, for their home, for their environment, really allows true customization to meet a medical need for our patients today. And once again, it's not what the patient necessarily wants, but it's determined based on a medical need. So from here, we'll jump into billing codes and claim handling. So there are 2 ways we typically see ancillary products and services billed, through what we call HCPCS codes. HCPCS codes is a Healthcare Common Procedure Coding System. It was developed and maintained by Medicare. There are 2 levels of codes. HCPCS code level 1, typical CPT codes. CPT codes are based on services. So the patient's receiving a therapy, they're receiving physical therapy, they're receiving an image. Those services are typically billed under the CPT codes. HME for DME, DME POS, Medicare's acronym, level 2 codes. So that focuses on the DME, the O&P, and the supplies. So HCPCS code level 1 CPT codes, they were developed in 1966. The codes are updated annually. They have codes that are added, codes that are removed, codes that are revised. They're typically a 5-digit numerical code. They focus on services, evaluation, management, radiology, physical medicine. So, and here's just a brief chart based on those different services, the code ranges that exist. When you break those down into to those codes, each of those codes can have special modifiers. If you jump down and look at the radiology piece, radiology is typically the 70,000 series. You have TC, the technical component, which is the machine, the actual photo, the actual picture of the image. The PC is a professional component. So that's the person who's doing the reading. That could be the doctor, that could be the technician. And then you have global fees. Global fees are the most common in today's market because it takes and combines both those into one fee. So they typically bill with just the code and not a TCPC today. But those do still exist, and they still exist in some fee schedules. Physical medicine, 97,000 series, BR by report. So there may not be an established reimbursement, but there's a recognized code, and a modifier of BR identifies we will review this as a by report code. So HCPCS code level 2, DME POS, once again is focused on the DME, includes products such as the hospital beds, ADLs, transportation, CPM, cold therapy, medical supplies. It's a 5-digit alphanumeric code consisting of 1 letter and 4 numbers. The letter typically segments the product type, such as DME. DME typically is billed under an E code or a K code. ADL codes are various codes, transportation are various, and we'll talk a little bit more about coding here in a minute, some of the challenges with the coding. But CPMs, E codes, EO935, and the EO936. So medical supplies, A codes, O and P, L codes. So here are some of the challenges with coding. You have special cases. Everyone's favorite code, I'm sure, is the lovely E1399. It's a durable medical equipment miscellaneous code. That code has a purpose in the marketplace, but many times that code is abused. And when I say it's abused, that providers have a tendency to apply that code to a product because they don't feel there's a fair level of reimbursement. When you see that code come through, there's times to question that code, and if you ask for the supporting documentation or information, you can truly identify if that code's really appropriate or not. And also you may reach out to your ancillary benefit manager and look for them as a resource. The other codes are A codes, can go to DME, supplies, ostomy, incontinence. And what happens with the miscellaneous codes and the special case codes is that there's no level of reimbursement set by Medicare for those codes. A couple other issues are what we would call gap codes and the bariatric equipment, which we'll touch base on in just a moment. But for the gap codes, so Medicare has assigned a code to a product, such as cold therapy, the E0218. It's a gap code, and what that means is there's a description been created for the code, but there's no set level of reimbursement for it based on Medicare. And Medicare doesn't necessarily pay for that product. They don't recognize that product, but they've set the code up as a way for billing the product. So it may take under special considerations, but it's not recognized as a code for payment directly from Medicare. Excuse me. Bariatric equipment, it can be billed with a miscellaneous code. There are some core products that have codes, such as the EO302 and the K007, which is heavy-duty equipment. But you do have bariatric equipment that falls outside of that for patients who are large, greater than 350 pounds, can exceed 600 pounds. So there's some reasons for the equipment does fall outside, and you will see those products and services billed under the E1399. Once again, asking for supporting documentation, letters from medical necessity, can help justify why some of those products may be billed that way. So just a brief overview for selecting DME. So we'll walk through ambulatory aids, bathroom safety, hospital beds, wheelchairs, CPNs, and cold therapy quickly. So all of these products shown here, these canes, they're all billed under an E0100 HCPCS code, except for the quad cane. Quad cane would be billed under an E0105. Both of these codes are recognized by Medicare, but you can see that each of these products are a little bit different. Single tip cane, it's very inexpensive. It's best for maneuverability and mobility. A quad cane provides a little more stability. It's harder to overcome. It's hard to maneuver. It's not good on a set of steps. Wood cane, it's made out of wood. There's no type of adjustment on that cane. The cane is what it is. It has to be either cut or purchased at the right height. Aluminum cane, basically the candy cane, very common, does have pin adjustment. Folding cane, folds, sticks in someone's purse. But once again, they're all billed under one HCPCS code, except for the quad cane. The cost can vary significantly for each one of these products. Crutches, basic ambulatory aid products, underarm crutches and forearm. Underarm crutches are typically armpit crutches, best for short-term use. They're easy to learn to use, but the patient does risk hunching and chafing of the armpits from the crutches rubbing up against them. Forearm crutches or elbow crutches are better. It allows the patient to be upright. They're better for long-term use, but they do take longer to master, and they do require also good upper body strength. Walkers, standard and rolling, provide stability for the standard walker. You have to lift it each time you move forward with that walker. So the patient has to have some level of upper body strength to lift that walker. Both of these walkers do fold. The rolling walker simply rolls forward. There's no need to lift it. The patient's able to move faster and requires less effort. So bathroom safety equipment, tub benches, transfer benches, rolling shower chairs, commodes, toilet seats. Tub bench fits fully inside the tub, does not extend outside or over the tub. A transfer bench will sit halfway in the tub, with the back being in the tub, and half on the outside of the tub. Allows the patient to easily transfer from a wheelchair onto the transfer bench, slide in, and suction cups hold the shower chair in place, the transfer bench in place while in use. A rolling shower chair will require some type of home modification that allows the patient to roll into the shower chair. This is a very low-end shower chair we're showing here, but some of these come into play with full-size wheels and tires, such as a wheelchair. They also have a tilt mechanism. They also have commode features. The actual commode can be used over an existing toilet, so the patient doesn't have to go down as low. It makes it easier for getting up and down. They can also use a 3-in-1 commode next to their bed. Toilet seats clamps directly onto the toilet. There are handrails available for the patient to ease themselves down and to assist in standing. Once again, relatively inexpensive products, excluding maybe the rolling shower chair, but provides a great deal of safety for your claimants. Hospital beds, once again, 3 major types: manual, semi-electric, full electric. Typically have a basic mattress. They're also used many times in conjunction with a low air loss bed as well, or low air loss mattress. Manual beds are totally manual in the sense that to raise the head, to raise the feet, or to rise the bed itself, you have to manually crank those beds. Not very common today. The most common is a semi-electric. The head will rise, the feet will rise based on electronic controls. The manual height of the bed is still by crank. But once again, it's the most common bed, typically out for rent. It's an E0260. The full electric is an E0265, which all parts become electric, where the head will rise and the feet will rise. Typical major difference for a semi-electric compared to a full electric, you have a patient who's doing a lot of transferring in and out of the bed. The full electric brings great flexibility in raising the bed, and lowering the bed very quickly and easily for a patient or for a caregiver to get the patient in and out of the bed. Wheelchairs, once again, standard, lightweight, custom, and power. So you can have a standard wheelchair, 18 by 16, swing away footrest, the day in, day out chair that's rented. With those chairs, there are limited functionality that you can change on them. Maybe it'll change the length of the armrest. You may be able to get a chair that's 20 by 20 based on the patient's height and their weight. But the functionality is pretty limited. They're typically heavy. It's more of a hospital-type based chair. A lightweight chair is about 7 pounds lighter approximately. Depends on the exact chair, about 7 pounds is good average. You can have a lot more flexibility in that chair. It's lighter, it's more portable. You can make modifications to those chairs very easily. Custom chair, once again, is where someone's been evaluated and assessment's been completed. That shows what that patient's needing to meet their injury needs. Power chairs, once again, they can be custom as well. They can sometimes be available for rent. It is difficult to find them, but a basic power chair can be found for rent periodically. There is an assessment that should be done for any power chair to make sure the patient, number one, is safe in the chair, and secondly, that the chair is going to meet their medical need. So for DME, CPMs, some average usage. So when we talk about HCPCS codes, Medicare recognizes the E0935 knee CPM. That's the only code that Medicare recognizes for CPMs. The E0936 is a gap code that's been created. Medicare does not reimburse for any CPM outside of the knee, and each one is billed under E0936. So here's just some average usage for each of these products. Knee CPM, 7 to 14 days, pretty standard. Shoulder, 21 to 45. The wrist is the most lengthy use of a CPM. That's because in our hands we have many small bones that can be crushed, a lot of crush injuries. 60 days isn't uncommon. I've seen some of these go on for 6-7 months. We're trying to bring back that full range of motion back into the patient's hand. Cold therapy units, ice buckets to DVT. So an ice bucket, gravity fed, hangs on an IV hook, let's say, and there's just water going through ice draining into a pad that's been attached to the patient. Motorized, continually pumps the water and circulates it through the pad. A game-ready unit, it's a brand name. It's been around for a while now. Those units, you can do time compression, so you get compression, you get cold therapy, and you can also do tracking of that device and the usage of it as well. The DVT unit is a new unit that just hit the market, and it's really a combination of DVT, cold therapy, and or hot therapy, and provides compression. The one thing I would caution on cold therapy is really questioning the physicians. Why are they dispensing this type of cold therapy? As we talked about earlier, there are companies who go out and they market their products to the physicians, to the clinics, and they store those products. Not uncommon with cold therapy. The difference in cost between a motorized cold therapy unit of, say, $300 compared to a game-ready unit at $65 to $85 per day, and a DVT unit falls in that same range. The difference in cost is substantial. Because those are both rental units, and those units would rent for probably 14 days. And there are accessories that go along with it. So they're very costly, very expensive units. And many times the physician was just marketed by the local rep, so he's writing that unit for XYZ brand, and they dispense that unit when really all they needed was basic cold therapy. So some average utilization and cost. So canes, walkers, crutches, ambulatory products typically all three are purchased items. The short-term to lifetime need, 1 to 3 months for the crutches. Average cost for a set of crutches, $35 to $150. Those canes that we talked about, the variance in cost, $18 to $50. walkers, $50 to $500. And these are just retail averages. Bathroom safety, $20 to $400. If you get into the roll-in shower chair, that could easily hit a couple $1,000s. Hospital beds, short-term to lifetime need based on the injury, rental $150 to $1,500 a month, and purchase $700 to $10,000. That high-end rental and that high-end purchase would be those heavy-duty Gendron type beds that are supporting the patients of 600 pounds or greater. Standard wheelchairs purchased or rented, short-term to lifetime need based on the injury, rental $65 to $165 per month, purchase $200 and up. Aid to daily living, purchase to short-term lifetime injury based, short-term to lifetime based on the injury, $10 to $300. CPNs, any place from usage of 21 to 45 days, $25 to $65. Cold therapy can be rental or purchase. Once again, your basic cold therapy works in most cases, but you do have the Game Ready and DVT units, $60 to $85. Purchase of all other types. You can't purchase the Game Ready units or DVT units typically, so they're between $7,000 to $10,000. But basic units, $150 to $450. Medical supplies, you can have medical supplies. You can get one gauze, 2 cents, or you can get. It just depends on the supplies. The one thing I will say about supplies, patients today, and for as long as I've been doing this, become very brand loyal. And if you have a patient who wants a barred catheter, and that's what they've been using from the point they were discharged from Shepherd, then that's what they want to use for the rest of their life. And trying to convert patients to off-brand or generic type supplies is very difficult. They become accustomed to those products and become very loyal to them. So there's a big variance in cost on supplies. But once again, that same catheter, that catheter might be under an A4502 for a catheter that costs $1 or $7. So conclusion, here's what we've seen today, is that DME is commonly prescribed for injured workers. It's lower cost than the hospital, improves recovery time, it gives greater mobility, helps in the involvement of daily activities. DME and ancillary services make up a significant portion of care and cost in workers' comp claims. The other thing I would add is that these services can be difficult to coordinate, so looking to ancillary benefit manager companies is a great way to manage these for cost as well as coordination. Product selection is important to managing utilization and cost. Know your HCPCS codes to ensure consistent processing and billing. Ask for guidance and ask for assistance where needed. Thank you for the opportunity of speaking to you today. I'm going to hand this back over to Lori for a moment, and thank you for your time.
Thank you, Chuck. We have gotten some questions in, so please go ahead and if you do have questions, submit them to us in your chat pane, and we will try to get to as many as we can. One that came in was going back to Chuck when you were talking about physician dispensing of DME, and somebody asked, how can a physician dispensing of DME not be a referral, or not considered a referral?
I'm not quite sure if I understand the question, but I'll answer it the best way I can. The physician dispensing equipment can be a referral, and those physicians do dispense the equipment. The challenge is when they dispense that equipment, the charges that come back to the insurance company may be significantly higher than what would normally be reimbursed through one of your direct relationships. And that referral happens without authorization from the adjuster or case manager.
Okay.
And I just hey, Lori, I just would like to add in there that it's similar to the physician dispensing issues that we have on the pharmacy side, and the fact that the regulations in the various states does not prevent the physicians from doing that activity. So because it is allowed, it does make it more difficult for us to manage that aspect when the doctors do dispense within their practice. And as Chuck said, it can really impact us on the back end when we find out about it, because we didn't go through the proper procedure for authorization, and those costs are going to be higher.
Okay, thanks, Jean. Yeah, that makes sense. Another question we had come in was, I have seen knee and shoulder CPMs for much greater periods, for instance 45, 60, 90 days. All claims are different, but is there a guideline for standard approval duration?
Normally I would say that I have seen many cases where CPMs do extend beyond the normal usage. 14 to 21 days for a knee CPM would be pretty average. There, of course, are complications in surgeries, and the healing process is different for each individual patient. But on average, 21 days for a knee CPM should be the norm. And that's what I would seek if someone's asking for additional authorization beyond that 21 days. I would seek from that provider additional medical documentation supporting why.
Okay, the next question asks, why is it that we can go down to our local pharmacy or sometimes retail store and commonly get crutches for maybe $20, but it's rare to see a DME company provide crutches for less than $45?
There are many aspects involved in that. There's the coordination of ensuring that when the adjuster and case managers are going out seeking products from a local company, there's time and effort being spent on doing that. And there's a cost associated with that. And we're able to bring in many of those services, coordinate those as a central point of intake, coordinate many different aspects way beyond just the crutches, and have a central point of billing for those products and services. And then those services are managed throughout the lifetime of that service. So the patient's receiving an ongoing piece of rental equipment. Those products and services are then called on monthly to ensure proper need, ensure medical documentation is provided, and make sure all that information is available for the adjuster and case manager.
Jean, did you have anything to add to that?
No, I just would echo what Chuck said and state that there are more aspects. It does sound like it would be easier just to go out to the local drugstore and get the crutches, but then you do have to worry about did the patient actually receive training, and if it's an ongoing need, if it's especially a rental equipment, are they really using it? The follow-up, and are they using it appropriately, becomes key. And to also coordinate that for the nurse case manager and the adjusters on the claim so that you have the documentation back. And the billing becomes a bigger issue from a higher level perspective of your, from a carrier payer perspective, that they want everything to come into one central place versus the one-offs of trying to manage that unique, if it's a mom and pop pharmacy down the street, et cetera, or even Walgreens can be interesting to deal with at times.
Okay. Another question, Chuck, that we got in was, does DME get returned or is it disposable?
It depends on the piece of equipment. DME typically, as defined, can withstand repeated use. So DME, if it's a rental item, those products, anything that's rental can be picked up and returned back to the provider. If it is an item that was purchased, then it remains the property of the patient and or the insurance company. But most organizations today don't have a way of, I can't think of the proper term, a way of storing that equipment and then redispensing it back out for the payer for another patient.
Okay, the next question we got in was, is there a place that I can have access to the codes, all the HCPCS codes that you went through? Is that available somewhere?
There's coding available, and it depends on the companies that you use. As myMatrixx, we normally have all of our products are coded through our web portal. So there are access tools out there for other organizations that you can get from CMS that you're able to do code searching to identify what the appropriate code is for the appropriate product. There's a program called Encoder Pro that's put out by, I believe, in Gen X, that allows you to do code searches.
And
okay.
usually those Encoder Pro, they do require a licensed user fee.
Yes.
But some of the larger carriers may have, their nurse case managers may have access to that. So if you're an adjuster trying to find out more about HCPCS codes in general, you may want to get, if you have access to nurse case managers, ask them, because typically very knowledgeable on HCPCS, especially if they've been dealing in catastrophic and complex case management.
Okay. We have some more time, so I'm going to try to get through a few more because we have a lot of questions coming in. Someone specifically asked about the game-ready compression cold unit that you mentioned earlier, Chuck. They wanted to know, has it been recognized per workers' comp guidelines?
It would really depend on the state and the ODG guidelines. How would they read it? Honestly, I don't know. I can't give you a direct answer on that. I do know it's been out there for a while. It's been around probably for about eight years now. Dispensed out of California. They have national distributors throughout the country, but I do not know specifically it's been recognized.
Jean, do you have any insight on that?
To my knowledge, I don't think any of the states have actually written that specific to that level of detail into their fee schedule rules and regs. So it is out there. You would probably, in most organizations, sometimes when it specifically for Game Ready and some of these other higher end, there usually are protocols within the payer that you would want to send that over to a nurse case manager for review, and it may actually go out for physician peer review too.
Okay. Going back to, we have another question about the HCPCS codes. Somebody asked, should the adjuster leave the correct HCPCS codes up to the bill review company?
So depending on the flow of the bills into your organization, when a request is sent over from the provider, if they're using the E1399 code, I would question that if they're asking for an authorization request. And if someone's asking for auth, you're fine asking, how are you going to bill them? What's this going to be billed under? And if you hear them say it's going to be billed under the E1399, asking for justification up front, why that's being billed that way, is a proper question, I believe. The bill review organizations can go back and review those codes, and they can they will make adjustments to the bills in many instances, but is it the appropriate adjustment for the product being dispensed? It could be a questionable guideline.
And I will say this, Lori, about DME overall. For medical services, physician visits, like Chuck was stating earlier, for services, physical therapy, that kind of thing, those services are typically covered by state fee schedules. DME and home health care, not quite as much into the level of detail where you can get consistency from state to state. So it really does vary, and that's where your medical bill review partner, or if you're doing it in-house, typically will have rules around that when these codes come in to either take another look at it, make sure there's documentation that supports those miscellaneous codes when they're used, and other things they may have rules built in along with ODG guidelines, et cetera, to try to sort through that and to make sure that it is being used appropriately.
And Jean, that's a great point, because I know there are certain states, and I'm thinking of one in particular, that if an E1399 is billed, the fee schedule states that they can do a reduction of X%, and that X%, I believe, is 40% or greater. They will just whack the bill based on that.
Okay. I'm going to try to see if we can get to maybe 2 more questions. Thanks for sending. We're getting a lot of questions in. For any questions we don't get to, I just want to let you know I'll follow up with Chuck and Jean and see if we can just get back out to you via email individually. The next question we had come in said, sometimes my injured workers are sent DME without anyone showing them how to use it. How can this be avoided for such things as CPAPs and CPMs?
In no case, in my opinion, should we ever send out, or anyone should ever send out, a CPAP or a CPM without having someone physically do a delivery, set up an instruction of those products. Those are products that that CPM needs to be applied. The patient needs to be educated. They need to understand how much progression their doctor is recommending to make the adjustments for each day. Typical progression, they're trying to get 5 degrees of extension or flexion each day. So they need to be properly educated. So that should not happen from an organization.
Okay. Jean, do you have anything to add from your experience and training and education?
I would agree, because if you send it out, If you're finding that is happening with some of your injured employees, some of your patients that you're trying to manage, I would probably get that up your chain of command to make sure that your manager is aware, because there may be other things that should be looked at if it is going out to the patient without any kind of instruction, because that could be detrimental to the patient as well as also impacting your claim long-term exposure. I mean, what if they started using something inappropriately? It could lead right back to a hospitalization, which is going to be more costly.
Okay, thank you. One more coding question. That seems to be a big topic. This is very specific, Chuck, so we're going to test your coding knowledge. It says EO218 was removed from the feed schedule. Is EO217 an acceptable code?
That's the E0218 is the cold therapy code. The E0217, and forgive me, I don't know off the top of my head what that code is, so I can't really answer that. I want to say it's a type of heat therapy and not cold therapy. But off the top of my head, I'm not sure. I'm sorry. Okay. We'll research and find out for you, though.
And also, that could be jurisdictional driven.
Okay.
Yes, most states don't even recognize the E0218 as a code at all.
Yeah.
So they're used. There's no fee schedule, no amount established for them.
Okay, great. I think one final question, since we're on codes. Who controls setting up new HCPCS codes? I know you mentioned earlier Medicare manages it. Are they responsible for setting up new codes? And maybe give us a quick little insight on how that happens.
So I'll provide the knowledge that I have on this, Gene, and if you can add anything to it, that would be great. My understanding is that when a new product is developed, there's a process that the inventor or the manufacturer of an item will then submit that item to Medicare with a description, and Medicare will then assign the appropriate code or CMS to that product if it exists, if there's an item that matches. And that's kind of what happened with the CPMs. For the longest time, EO936 was the only code that existed for CPMs. The other CPMs were typically built under E1399. And I believe it was Ortho Rehab, who was a large distributor of CPMs nationwide, who actually submitted the paperwork to Medicare to Medicare CMS to establish a code.
Do you have anything additional, Gene, on that, or?
No, I don't. It just they do have to submit of why they want it to be allowed by CMS, and it is a lengthy process to get the HCPCS updated, especially if you're new. Then you usually have to present research also.
Great. Well, thank you very much. Thank you, Chuck. Thank you, Gene, for spending time with us today. Again, we had some more questions we couldn't get to, but we will definitely go over them and follow up with the individuals that submitted them. We really appreciate you taking time out of your schedule today to join us. Again, look for an email coming very shortly that will have a link to register for CE credits. And we are recording today's session, and we're going to make it available on our website in about a week's time. So if you want to watch it again and go over some of that information or forward it on to your colleagues, please do that. Thanks again for joining us, and have a great day.